And with that, I'm going to roll into today's session, which is the promise of PrEP versus the reality of access. And we've got Akeem Rollins and Emmanuel Harvey joining us today, who are going to talk to us about the promise of PrEP versus the reality of access. So let me stop sharing my screen, and we'll have them come on and introduce themselves. Thank you both.
Hi, I'm Akeem. I work at Metro Health in the Early Intervention Services, part of the Infectious Disease Department. And I also work as a research specialist, which I'll tell you a little bit about later. I've been a PrEP navigator for this past August 18th, I think it is, was my 6-year anniversary as a navigator at Metro. And I was recently promoted to the lead navigator because HR said we have too many supervisors in our department. So yeah, that's a little bit about me. And I will let Emmanuel introduce themselves.
Hi, everybody. My name is Manuel Harvey. I use they and he pronouns. I am a peer educator, a NMAC fellow for the 2024 year. I'm also an educator, a spoken word artist. I wear multiple hats, but I've been involved in public health for over a decade, so I'm very excited to share my experience with you all.
Cool, thanks. I am too. I can't wait till we get to that part. But let's jump into a little bit more about PrEP, promise versus the reality. So I'm sure that many of the people here know about PrEP, at least, and have a really good working knowledge. So we're going to get a little bit more into like the weeds of what is preventing or some of the barriers that are keeping people from getting into PrEP. There we go. And turn those subtitles off because I don't like to see my words pop up. All right. So I'm gonna kind of introduce a little bit more about what I do as far as EIS, navigation, and research. All of it kind of ties together into a nice prevention package in the shape of a 6'4" man in front of you. And then we're going to talk a little bit more about access, some of the progress, and some of the barriers. I recently got to go to the USCHA, United States Conference on HIV/AIDS, and I learned a great deal about some of the barriers that are coming down, even from a policy level. So it's not solely individualized. And if you've been in public health for 10 minutes, you know it's not generally about the individual, but about the structures around the individual as well. And then we're going to hear from Manny, and I'm going to share some of my experiences as someone who has been a PrEP patient for 9 years now. I can't even believe that I started that long ago. And then we're going to have some Q&A, some questions, and we're going to wrap up. Oh, and that's our website. Pop to Block is the website that we use, that we kind of created in partnership with for outreach, especially during the pandemic when we couldn't go and like actually see people. So we wrote blogs, we have a social media campaign, we made commercials with iHeartRadio, so really trying to still be present and increase awareness because, as we'll get into, one of the big barriers in a lot of populations that are priority or said to be priority populations is awareness, not just that PrEP exists, but like, what is it? How do you take it? How do you get it? People are concerned about side effects, what it does to you. And there's just a lack of really good available knowledge that gives everything you need in a good package. So we'll get to those things. All right, so what I do. First off, I'm a nerd, so I have on Spock ears, but PrEP navigation is kind of like the main thing I do. And I tell providers that I work with past, present, and future patients. What that means is patients who may have been good candidates for PrEP or may have had some factors that make them a good candidate. And I'll go and find those people and help them get connected to care. People who are currently being seen in clinics, that's pretty self-explanatory. But future patients are, I work with our PEDS department and other PEDS department so the Peace Department at Metro Health and other pediatrics departments where people are just starting to become sexually active. People whose circumstances change, whether they are recently divorced, recently out of a monogamous relationship, or even people who may have different relationship structures, because not every relationship is monogamous, and just because you have a patient that is in a relationship does not mean that they have one sex partner or one source of sexual vulnerability. So I work with Gilead, Merck, ViiV, My Good Days, Patient Assistance Foundation, Patient Assistance Network. So foundation funds and manufacturers directly to help pay for the actual drug. And that's through assistance programs and copay cards. And those are two examples on the right of what those look like. And we can get those electronically, which I find to be the best method. And it's not only the best, but it's also just faster. Anything that lowers barriers for people trying to access PrEP. But for office visits and labs, we have the PAPI program, the Patient Assistance Program Intervention. That is an ODH program that was started in 2019, but there were a couple years where particularly Zach Rowe and Rustin Zamarodi, and here in Region 3, Josh Kretz, were going around and we were having PrEP work group meetings in Northeast Ohio to kind of craft this program to make it as barrier-free as possible for people to access PrEP. And one of the barriers was paying for PrEP, having to be seen, and some of the people that were accessing PrEP didn't even go to doctors regularly. So having to be seen from maybe once, twice a year to a minimum of 4 times a year for testing, for to get your script renewed, all of those things, that could have been a big financial barrier. And so that was a part of what the PAPI being created and crafted was. I work with insurance, and if you have to work with insurance, you know it's not an easy work with, sometimes work against, and with prior authorizations, trying to get people covered for the PrEP that they and their provider have chosen. Oftentimes, insurance would try to dictate what kind of PrEP is covered, even if it's a kind that is indicated that the patient can't take or would not benefit from as much. So there are some people who can't take Truvada, probably for a number of different reasons, but like, let's say for nephrological reasons, or they have some sort of kidney disorder, and they would be a better candidate for Descovy, but the insurance is saying, we won't cover Descovy because we only do Truvada and we only do generic. Well, they don't get to decide that, especially if the doctor has a good reason to say this person needs to have this specific medicine for this specific reason. And I work in our EPIC medical record system. I do education, counseling, those sorts of things. And I think a big part of the education and counseling happens with people who are oftentimes younger, but not always. But younger people in this area, but in this nation, have a big lack of sexual health education and sexual health education access. Ohio still doesn't have very good sexual health education laws. We don't have bad ones, like some other states have laws where you are supposed to. If you are teaching sexual health, you have to speak about LGBTQ sexuality in a negative way. So that's even any gender that is outside of the binary, any sexuality that is outside of heterosexual, you have to speak about it essentially in a negative way, or not teach anything whatsoever. And we see a lot of that rising all over the nation too. So oftentimes people will come in and they may have engaged in oral sex one time for a short amount of time, and they think, oh God, I have everything under the book, because there's no access to education. And Google is free, but Google also gives you all of the information and forums and access to people who also don't have the right information. So it can be a bit tricky. So education and counseling is a big thing I do, especially with not just young patients, but like youth groups, GSAs that still exist, and LGBT centers around. So that's a big part of what I do. I'm also working when I in the EIS program. We do a lot of, well, we don't do a lot of PEP, but we do a good amount of PEP. And unlike PrEP, PEP is an emergency, meaning we have just a 72-hour window to get people PEP. And so oftentimes I'll have I have a provider kind of on standby at any time. There was one particular instance. It was a Saturday night. Someone was shipping off to the armed forces that Monday, and they had an exposure the day before. And the emergency room had no idea what to do with their insurance. It was United States, the branch of the armed forces they were in. It was their particular insurance, and they had no idea what to do, no idea what to charge it, no idea if anything was covered. And so they left with a prescription that was over $2,000, and they had no idea how they were supposed to get this covered. And by the time they got to me, it was almost midnight on a Saturday, and I still had I called up my provider, and also thankfully my friend, and said, "This is the situation. We need to get this person PEP like fast because we only have them for about 26 more hours before they're on the other side of the country." And so that's, I guess, a bit of more of an extreme example of emergency, but PEP has a short window, and it's also most effective if taken within 24 hours. So we need to get that to people very quickly. So that's part of the navigation that I do, and part of the assistance programs that we do. For example, the manufacturer of Icentrus, they will send the medication directly to an address. However, it's a 24-hour turnover. So sometimes we are even lower on time if the person needs that assistance program. We also started a Rapid Start program here at Metro for people who are newly diagnosed. And my supervisor, Jennifer McMillan Smith, Lewis, Catania, and Sahara Rivera, we all work in, it's primarily Jen who does it, and she's an amazing counselor in this, but she delivers the results all over the entire network, and we generally average one a week. Sometimes there will be four in 1 week, and sometimes we'll go a couple weeks without a new diagnosis, but generally we average one a week. And when she's unable to be two places at once, or if she's out, then I oftentimes cover that. And that has been, I think, some of the best advice I got was from a woman named Amy McCain, who was the previous director of the prevention department at Recovery Resources. And she said, it can be hard, but you have to remember two things. One, it's not about you, it's not your diagnosis. You aren't receiving this. It's about the person you're telling. And two, you are in an incredibly privileged position to be able to tell someone something that can change the course of their life. And what if you weren't there and they just didn't know? And so taking that into the room when I have to talk to people and have to give them what is a difficult diagnosis for most people, taking that advice, I've had that with me for oh geez, since I started at Metro, so 6 years ago, she told me this, and having that perspective really helps. Basically, all the stuff I do, I see a wall and I take a mallet to it. So any obstacle, my job is to knock down to get people covered, for PrEP, for PEP, or for Rapid Start, whatever the case may be. Also, a little bit about the research we are doing. Project Sexy is my primary research project, or research study. I'm calling it a project because it's also part of my grad studies, but Project Cersei is essentially people who have experience within the carceral system. We recruited them, and we're trying to create a mobile unit that can get people when they are first released from jail. So there's this gap happening. And this was a big theme at USCHA as well, HIV and criminalization, HIV in carceral systems, people who aren't getting access to treatment. or even access to PrEP, because oftentimes within the jail, they're in jail. They shouldn't be having sex, or when they're released, they don't have access to PrEP, to their prevention that they had access before. So what Project CERFSI is seeking to do essentially is just bridge that gap from release to home. So when people are coming home, they don't lose any of the healthcare they were getting while they were in jail, and they don't lose the healthcare that they had previously when they get out, and then there's oftentimes nothing. Or they may have been taken off of their insurance when they were detained. So that's one of the I guess, like, it's something I'm passionate about, but it's also one of the big things we're trying to cover here, so that we have less people just falling through cracks. And the PrEP sub study is another study that I'm working on. And I can get mired down into talking about research, because I think that's what grad students do, is talk about research all day. But those are two of the bigger ones that I'm working on. And so a little bit about the POPPY program, a little bit more. It is an ODH program, and it's supposed to pay for office visits and labs, which is oftentimes a cost that a lot of people don't think about. Even before, when I started on PrEP, I didn't think about how much the office visit itself costs, or the labs even. And because there were manufacturer programs, there are medication assistance programs, but there's really not a lot to support people getting other costs covered. And so that's what POPPY is created for. And to qualify, you just have to live in Ohio, be HIV negative, and you have to have an income under 500% of the federal poverty guidelines. And POPPY pays providers directly. So the patient, it's another way to just lower a barrier for a patient. It's not, here's the money for the thing that you got, now go pay that, which, to be honest, if you just gave, like, let's say someone had a $500 bill and you just sent $500 to a 20-year-old, and now they're like, well, I have $500 I'm supposed to pay for this bill, to pay this bill, but I also have 100 other things I have to worry about. It can be a little bit of a catch. And just to be, like, more clear, POPPY generally does not pay for the drug. It can pay for some pharmacy copays if the pharmacy is in the POPPY network, but that is a little bit more of a complex process to get pharmacies as POPPY providers. So yeah, and that's, I work in Region 3, right up there. Lorain, Medina, Cuyahoga Lake, Geauga, and Ashtabula. So let's get a little bit more into PrEP access. Just to check real quick, Adam or Zoe, do we have any questions so far?
Yeah, we've got one question in the Q&A that says, there are some people living with HIV that think PrEP should not be used. What are your thoughts?
Okay. My first thought would be, why? Why shouldn't it be used? And I kind of want to start there. I think a lot of times I approach things from more of a conversation of, like, okay, this viewpoint it's fine to have, but why do we think this? What is it about this particular method of prevention that is, I guess, I don't want to say deleterious, but seen as something that should not be utilized, as a tool that shouldn't be accessed? So my first thought would be, why? So that's my answer.
That's a valid answer. And that right now, that's the only question we've got.
Cool. Let's keep going. Thank you, Ada. So PrEP access. So we have been seeing that overall, PrEP prescriptions are going up, especially amongst the people who could benefit from it. And this is a good thing. I also think that part of what's happening is that more education, and I don't mean just community members. When we talk about education, I oftentimes mean providers, providers knowing about PrEP, that it even exists, providers who are outside of ID or even primary care, knowing that PrEP is a thing, um, and providers having comfort prescribing PrEP. Um, I often come across providers who have a lot of hesitancy because they believe PrEP is a bit more complicated to prescribe than it actually is. What we need is this an HIV negative person in front of you? Okay, let's get them a prescription. Other things we can figure out in the 2 weeks, 30 days, if it takes that long, it takes to get the labs back. And there have been OBGYN providers that I have helped prescribe PrEP. There have been nephrologists that I've worked with who have prescribed PrEP. So PrEP can be prescribed by any provider that can prescribe. Um, I just think that there are not enough providers that are aware of it and aware of how easy it is to prescribe PrEP. However, I think those trends are changing, and this graph indicates that. However, as we can see by this next graph, the priority populations are not being reached as effectively or as efficiently. Even in the earlier days, PrEP uptake was largely white gay men. And we can see that for the most part, at least in 2022, I think these numbers have also increased since. We've pretty much reached the PrEP coverage goal for white people. And we can see that in 2022, PrEP coverage by people who could benefit for Hispanic and Latino people it was at about 24%, and Black and Latino people were just about half that at 13%. And so we're really trying to figure out all of the whys behind this, and it's complex. I think, again, if you've been in public health for 10 minutes, you know that it's not about just the individual. If you've been in public health for 11 minutes, you learn that everything is complicated. And everything can be boiled down to the historic failings of the system that we're working within. So there are many, many different reasons that we're going to go into, hopefully later, why this is the case. And I'm pretty sure that you can think of a few of them without me having to be heavy-handed with the answer. So some of the barriers, like I was talking about before, provider hesitancy and knowledge. So it's not just that providers don't know about it. Oftentimes, patients are coming to providers asking them for PrEP or telling them, I want to be on PrEP. And then providers don't know what to do with that. That may be the first patient that has ever said that, or the first patient that they have had that is the first patient they've ever encountered who was trying to get PrEP from them. And so they don't know what to do. And so when they learn about what PrEP is and what it's used for, they'll try to refer out. And that is, I know that that's likely done with the best of intentions, but that's another barrier, especially for people who are very busy. We all have lives. And so to make the time to go to an appointment and then be referred to another appointment, that's not completely necessary. It is not necessary to refer a patient to an infectious disease department to get PrEP. It's just not. But that creates another barrier and more time in between. So in that time in between, the person can not be able to make that appointment. They can forget about the appointment. They can seroconvert. They can go, this is too complicated and I don't really want to get it anymore because I thought it would be easier. There's so many things that can happen between the referral, that's not necessary referral, and the person actually getting the prescription. Insurance coverage can be a little difficult, especially with, so Medicaid is generally fine with covering PrEP, I'll say that. But when you get into private insurance, marketplace, employer insurance, they have their fee schedules and formularies and things that they cover and things that they don't want to cover, prior authorizations, all of this, it can be very difficult. And if a patient is doing this by themselves, it can feel impossible to know how to do all of this, or even that you know to do this. You think something is covered, you go to the pharmacy and they say, please, $1,800, please. You go, well, I'm not paying that for a month, and you leave and you think this is too expensive, I can't do it. Or you try to figure out how to get it. Um, you call in between providers. And so you're talking between the provider, the pharmacy, the insurance company, and you're triangulating that. You're on hold for 3.5 hours, and then they tell you you need a prior authorization, which you've never done before. So it can be really difficult. I'm oftentimes working on like some of the more complex of my complex cases, and I'm like, if I had to do this by myself for myself, I would just say forget it, because we don't understand. What I think that oftentimes we aren't addressing is that prevention is kind of nebulous. It's this, I'm taking this drug to prevent this thing that might maybe happen. It's kind of like any prevention. It's kind of like insurance. I have it for just in case this thing that might not happen does happen to me. And it might happen. And so it's again like insurance. You're happy when you have it. However, it's a nebulous concept that's not concrete. You're taking this to treat this for this long. So it's an easier thing for people to say, this is too complicated. I'm not going to do all of this. And it shouldn't be this hard. There's also, like I talked about, the barrier of time. No one has time to sit on hold for 4 hours. Um, there are structural barriers. Some of those structural barriers are as simple as transportation, as simple as having to go from a doctor's office to a pharmacy, and find the time to do all of those things within the time that you need to get it done. Education and vulnerability awareness especially amongst all of the priority populations, is difficult. I think that we have a surprising lack of multilingual or bilingual information available for people who could benefit from PrEP. Um, and I think that there are people who may want to. And at Metro Health, we do serve a very large, very diverse population of people who don't speak English as their first language. And so we need to have more of the information available in ways that people can understand. Um, and people are not oftentimes aware of their vulnerability to HIV. Um, we oftentimes talk about like young people thinking, oh, well, that's a thing that won't happen to me. Well, that's not the only population that may think that. They may not even know that it's a thing that's happening at all. HIV hasn't been sensationalized for 20 years about. It doesn't show up in the media as much. It's not this big, scary thing that we have no idea about. We get it. People are living and living well with HIV. We know we have many ways to prevent HIV. And so it kind of disappears from the public eye, and we have a lack of sexual health education. So that combination makes for a pretty jarring experience when you talk to a room full of people and they go, HIV still exists? Which is something that has happened to me as early as this year. Um, so people are not always aware of the vulnerability, and it's not an individual thing, it's a systemic thing. Um, and also we talked about the cost. PrEP can be expensive. The Not just the medication itself, but everything around PrEP, the labs and the office visit and having to call off of work if you have to call off of work, and transportation, et cetera, et cetera, et cetera. Anything that you have to do to get something done can be a barrier for someone who does not have access to that. And then we get to stigma. I think that as far as PrEP is concerned, PrEP stigma has decreased significantly in the past maybe 3 to 5 years, especially since it was approved in 2012. We have a lot less people being called PrEP whores, but it still happens. People still have a belief that PrEP is either only for gay men, um, or only for people who are out here or having a lot of sexual partners or who are sexually successful, sexually adventurous. And that's just not the case. It's just not true. I say PrEP is for anybody that wants it. Um, and PrEP is for people who have, and I like to stay away from just pigeonholing and siloing, saying that we have priority populations and they're the ones who need PrEP. I think anyone that wants PrEP is motivated to get PrEP and wants to prevent HIV, um, should be able to have access to PrEP. And thankfully, I'm not the only one that thinks that. So, we in the next slide, I'll talk a little bit about policy. But COVID, one of the great things that happened with progress in COVID is that we got a much better telehealth program across the nation. Really, we've seen telehealth be available, which makes it so much easier for people to get PrEP who may not need to come in for a 10-minute, 15-minute appointment, wait in a waiting room for an hour and then be seen for 10 minutes just to get their script. Telehealth is really driving a lot of PrEP forward, and we have a great telehealth provider here that I'm so thankful for. And the United States Prevention Services Task Force rated PrEP grade A for prevention. So we also have that. Um, However, that is in jeopardy. If you don't know about the USPSTF, um, they essentially go through, and I'll just talk about prevention. They rate prevention medications, devices, etc. And based on that rating, because of the Affordable Care Act, if something is rated grade A, it's supposed to be covered at no cost sharing for patients. That doesn't always happen. And we'll get into that a little bit. So some of the key opportunities, I think, is using the data that we have, that we're gathering, to drive forward what needs to be done. We see that there are populations that could benefit from PrEP that aren't getting it. Figuring that out, using that data, and driving forward our efforts to be a lot more concerted. And I think just public healthy, thinking about how to get these things to people in the most barrier-free way possible. Um, Timing, not delaying. Again, referrals take time. Making people wait for their PrEP takes time and takes time away. It also lowers the chance that a person will get or continue to take PrEP. Um, Having support and social supports around getting PrEP, navigation programs, referring people to navigators because we exist. We're here to help. Certain structural changes, and most of this is stuff I've already talked about, so not to belabor the point, and policy changes. Speaking of policy, um, there is a policy that the HRC is behind, the PrEP Access and Coverage Act. It was introduced by Democrats Tina Smith and Adam Schiff in 2023, and it would codify into law that private and public insurance um, have to cover PrEP with no cost sharing. Um, and there would be grant programs for states and territories for uninsured patients. A lot of that would be for states without Medicaid expansion, um, but others, so that people aren't forgotten about or falling through the cracks. And it's been referred to the Subcommittee on Health Affairs. However, we do have Braidwood Management versus, I think it's Becerra, but I can't remember how to pronounce that correctly. So something happened back in 2022, a very conservative court, and it was a concerted effort to get this specific judge, Judge O'Connor, in Texas, to hear this case where Braidwood Management didn't want to cover the medication. So essentially, the employer insurance did not want to cover a medication that they thought was against their values because it is encouraging people to have gay sex, essentially. You and I know that that's not what PrEP is, and PrEP isn't even just for gay people, but that's the way they spun it. And so the judge did rule in favor of the plaintiff, and so there are restrictions. So while Braidwood Management does not have to cover PrEP, that's not for any other employer. However, in the district court, so Judge O'Connor tried to make this a national law. USPSTF said that they were violating some stuff that I don't want to get into the weeds of right now, but they can't do that. So they are trying to get seen in the appellate court, the fifth appellate court, which is known to be a super conservative court. And this is really concerning because they can make a more expansive decision that could affect people across the nation. and they applied for a cert or a certiorari, where the Supreme Court will decide if they're going to hear it. If they grant the cert, um, and the case will be briefed and argued, and they can make a decision as early as next summer. And if they don't grant the cert, then it will remain, the remand process will still be in the district court, and a new case could be filed. So they really just need like one more ruling like this, and this could not just affect PrEP, but prevention across the nation. And millions of people could lose coverage to many preventative medications. So it's a bit dicey out here, which is part of why we exist as navigators and early intervention services folks, to help people get access to these things that there are people actively trying to get rid of. All right, speaking of access, let's hear from someone who is a PrEP patient. So Emmanuel, I'm sorry. I keep on calling you Manny. Emmanuel is an educator, a creative model, health ambassador. You heard him introduce himself. And they focus on promoting equity for Black queer individuals and improving health access to care for all. Sorry. And in their free time, Emmanuel enjoys modeling, traveling, and sharing experiences on Instagram. You can follow them at Hazel Thunder. That's no E on the Thunder, 2 R's. And Manny,
Hello, hello.
I would like to ask you some questions.
Bring them on.
All right, cool beans. So, first off, you sound so impressive.
Thank you. Thank you so much. I'm trying.
No, I mean, I think you're succeeding. I think you're succeeding. Tell me, when did you and how did you first learn about PrEP?
So I first became aware of PrEP, I want to say when I was 17. Well, actually, no, I learned of PrEP before that. So, I was a peer educator in high school, so I became very aware of not only sexual health prevention and treatment, but also about the specifics that are affecting the LGBTQ plus community, correct? And that included PrEP, which at the time was very new. There weren't a lot of research or trials into it, and PrEP also wasn't available to get it because it was something that was at the time not recommended for people under 18. And then on top of that, I would have to, be forthcoming with my parent about, my sexual activity. And that was something that I just did not want to get into that. So I waited until 18. And then I went to my doctor and I was like, hey, this is something that I would like. This is what I want to receive. And I was able to get it because A, I had insurance, and B, I was in college, and my college they had a program that offset a lot of the costs associated with it.
Oh, that's really cool. Do you know anything about that program now? It was a specific program or was it an insurance thing?
It was a combination, right? So, insurance pays a lot of it. I had a good program. And then also like different states and different colleges or different centers have different policies. So like for example, when I was in California, California has a program that they will pay for everything. Like they will pay for the labs, they will pay for the medication, and they will do it anonymously. So you don't even have to put your name on it.
Oh, that's
Whereas
cool.
Florida whereas Florida, where I was in Florida at the time, and this is a pre-DeSantis Florida. I will
Okay, specify.
So right, and very specific, very specific. So at the time they had programs that made I don't remember what the program is. Honestly, they just said like we help with the cost. And I was like, great, sign me up. But basically, because I was able to do everything at the student health center through my college offset a lot of it, and then they signed me up for the copay, so I didn't have to pay out of pocket. So that was a program that was available to me because A, I was at a public university, and B, my college's health center, they were able to do a lot of the stuff in-house. Now, that's not something that every college can do. That's not something that every health clinic can do. And we know that a lot of them end up outsourcing to different labs, different pharmacies, so on and so forth. I was just lucky and blessed that I was at a place where everything was able to be done in-house. So a lot of that stuff was able to be off foot.
So, speaking of that, it doesn't sound like you had a whole lot of barriers. As you said, lucky and blessed. So double whammy. Uh, what what barriers did you face, if any, when getting PrEP?
I think the biggest obstacle for me at first was, like I said, my age.
Mhm.
I I was not able, when I first heard about PrEP, to get it just because the research at the time, it was not available for people under 18, and that even if it was, that means I'd have to be forthcoming with my mom, who my background, I exist within the scope of a first generation American. My mom was born here, but my dad was not. So I'm in like a weird limbo. But I come from a West Indian family, and homosexuality is still very taboo. The stigma associated with that is very strong. And not only that, I think if I was forthcoming, like, not only am I gay, I'm like sexually active gay. I think I'm years. So I that just what that was the biggest barrier. Um, just age and being able to be forthcoming. Um, Now I would say that I I would say that on top of that, the other stigmas um would be, well, the other barriers would be a stigma. But I'm just one of those people, I can't curse on here, but I just don't give a F. But I will be honest that in my experiences with, other my friends, other queer people, cost is obviously one of the biggest ones. Um, luckily my insurance is strong and it's great, but people who don't have insurance, who have to go on Medicaid or other programs that are what we consider, lower end, that's a different set of barriers, different set of stigmas.
Mhm.
I also know that like I said, I was able to do stuff in house. However, if I didn't have a car in college, so if I wasn't, I would have to be transporting everywhere. That would be a
Oof,
different
yeah.
barrier. So yeah, so I would say specifically for me, the barriers were um, getting consistent access, because I moved states for college, and then I moved to New York, and I moved to LA. So the biggest barrier for me was just consistently finding doctors who were caring. I remember one experience um, where they where I um, because I was at the mercy of my university and their clinic, my old provider had actually ended up leaving, and I got a new provider. And when I was telling them these are the prescriptions I take, so on and so forth, he was like, "Well, do you think you really need to say PrEP?" And I was like, "What do you mean?" He's like, "Well, you're not HIV positive." I was like, "Let's just take a step back and
Oh
go over this."
man.
Right. So I think, like, some providers, when they hear PrEP or they hear um Truvada, they automatically think this is used to reduce their viral load. So they think, like, why would you need PrEP when you're HIV negative? Um, so I think that that was something that me as a patient, thankfully, I had the education where I had to tell my provider, like, well, no, PrEP is actually prevention, not treatment. Um, but honestly, I don't have a lot of those. I think that's also because of my age. I'm 25. And I was born at the when the HIV epidemic was reduced. So I'm in a world that is the post-AIDS epidemic, where a lot of stuff is very easily knowledgeable. However, if I was even 5 years older, that might look different for me, because that's at a different time.
Yeah, this is true. And that's another thing about providers. I know about a patient who was a college student too, like yourself, um, and a young cisgender heterosexual woman, and very knowledgeable, knew about PrEP, got PrEP, and then uh, got PrEP through a PrEP provider, and then their primary care provider put HIV positive all throughout their chart, and they saw that and they flipped out. And that was a patient that was lost because they didn't want to. They wanted it out. They didn't want to take PrEP. They didn't want to be associated with it anymore. And so that is a big thing. Providers can really, it's kind of like having a good supervisor at work. It can really make or break the
Right.
experience. And if you have a bad provider, it can just completely turn you off from even uh, engaging with
Yeah.
care and something that you wanted to in the first place.
Absolutely. I think on top of that as well, and we're talking about barriers, and I think my mind automatically comes to provider-based barriers or like legal-based barriers, but we also have to consider the personal. So
Mhm.
that could mean, I know plenty of people who this is before I'm not sure if people in the chat are familiar with the 211 method, where that's a shorter form of PrEP, but when I started taking it, we only knew it as take it one a day. You can't do it any other
Mhm.
way. But at the time, I would know people who are like, "Oh, I only take it when I'm having sex. Like the day I have sex, I take a PrEP pill." That's how it works. So I have to put my peer educator cap on. Also, let's say you rent out, you have to go pick up a prescription, your pharmacy's closed for the weekend. Like little things like that, the personal barriers we have to consider as well. Not just, and that might not even be a stigma. Some people have to set an alarm on their phone to take it. Some
Yeah.
people, yeah, and some people like I don't know if you've ever seen like the little keychains that people can put their little pills in. Some people
Yeah,
have to do
people
it
love
like that
those.
to set their day. Right. Because you don't know where you'll be that day. I think about people who are unhoused or who are sex workers or
Hmm.
who are drug users, for example, and they're just frequently not at home with their white bottle that by their nightstand that they can take it. So let's say if you don't even have a baggie to put a pill in or like a little keychain, like that's a prevention. That's a prevention that we could easily overcome, but
Yeah.
we just need the materials and the access to do so.
Yeah, like that, you bring up a good point because there are some people that are just for the first time being engaged in any care. And so they're not used to taking medication every day. But like I'm a kid that like had really bad asthma, so I always had some asthma thing, an Advil, a Flovent, a breathing treatment. I'm so used to having to manage my
Mm-hmm.
medication. And there are some people that aren't. And this is
Right.
kind of the first thing. I'm a big pill person in the way that I like taking my, as a vegan, my multivitamin and my medication at the same times each day. But there
Yep.
are a lot of people who don't do that or don't have access to that. There are other
Yep.
populations, people who may be engaged in drug use or sex work, or may not have the bottle next to them all the time. And so we
Yep.
do need multiple ways to have access. Um,
Yeah.
so speaking of access and all of that, what, in your view, why do you think more young people of color are not getting PrEP?
I think there's still a wide amount of distrust in doctors and medications. This whole
Hmm.
like Western medicine thing. Like some people are like, I'm not taking a white pill. I don't know what's in it. Especially because we have to consider as well, we're still in an opioid crisis where
Yeah.
people are dying of fentanyl, and because of that, people are scared to take medications even if it's picking it up at CVS, Walgreens, Rite Aid, because they genuinely don't know. I know people who, like the pharmacist accidentally did this white pill instead of this white pill, or this blue pill instead of this blue pill, and that can cause somebody to die. Like, this is serious. So, not only is it on that surface level, we also think about the historical implications. It's almost one of those things. Take a shot whenever somebody says Tuskegee. That's real. People still
Yeah.
talk about that. People like I even think about in Puerto Rico, like the forced sterilization. Like
Hmm.
people have historical reasons for why they do not trust doctors. And
Yeah.
so I think that is one factor, but it's also honestly, it might be a little bit of laziness too, because it's easy to fall back on that. It's easy to be like, I don't take white pills. It's easy to say I don't trust doctors because it's just geeky. When the real tea is, if we're being real, you just don't feel like going, or you just don't want that implication. There's still this thing of like a this is so funny, y'all. So I remember I was in another program where they talk to people of color about taking PrEP, and they were so they ask you like, do you agree or disagree with the statements and stuff, or like how strong agree agree, things like that, like a rating. And one of them was like, I fear taking PrEP or telling people that I take PrEP because of the stigma of being a PrEPor. And when I tell you, like, just reading the text, I just want to burst out laughing. Like, I was a PrEPor, like, but that might be a genuine stigma, because some people are not as open or honest about their sexuality, and some people, just because I might be comfortable talking about these topics doesn't mean that there's other people who are. So that might be a very real stigma. And even being honest, even me being able to be on this panel and talk to y'all about these experiences, that comes from a place of privilege. I had the time to come here. I had the time to talk to y'all about this stuff. Somebody who doesn't have access to PrEP and stuff, they might not be able to get it because they go 8 or 6 to 6, clocking in, can't go anywhere else. So I think that there's a wide range of economic factors, personal factors, but also considering the historical implications. And also, like you just said, there are somebody might not want to get PrEP because they're like, I might have it today and don't have it tomorrow. I don't even want to get used to it. Just because we're also in a post-Trump America where he stacked the courts, and we have a lot of governors who are rolling back rights. Roe v. Wade was overturned. So I think there's already such a fear or concern about people's medical rights that they still don't even want to get that access, because it's like, I might not have it tomorrow.
Yeah, very true. That was a lot of good information. And I think that you're very true. And one of the things about no, it's good. You're saying good stuff. I think that that's one of the things too, especially working in clinical settings. When people have medical mistrust, they trust something else. So they may trust grandma's method, where she would go and get the oh, what's it called? The gum seeds that look like little spiky porcupines, and like make a tincture out of that, or make some tea. That's something that's a little bit more Appalachian.
Teas,
Tea,
the pull-out method,
ginger ale, and saltines. They're they have. I think that people have certain ways to treat certain things, and they are getting information from someone. I can't tell you how many Dr. Sebi followers we have met in our clinic, who refuse to take treatment, but will follow methods that Dr. Sebi outlined. And so that's another part of medical mistrust. It's not just the mistrust, but who are you trusting? Because it's not no one usually. It's not, I don't do anything when I have a stomach ache or a headache, even something as, I guess, present as that. So I think that you were speaking a bit about like doctors and providers and professionals. What can we do as professionals that could make PrEP access easier? Even you were even speaking about motivation too. So what can we do?
To make PrEP access easier. It's funny. I was at the USCHA as well, and I'm a content creator, not that I'm a trader, but like a social media creator. So I
Yes.
was going around asking people like, what are the big barriers? And somebody had mentioned how a lot of our outreach is in the nightlife, or in places that only certain types of people go to, who are social, who like going outside, so on and so forth. And our marketing is also based on living a free, fluid sexual lifestyle. That could be barriers to people because they're like, well, I don't have sex that much, so I don't need to take PrEP. Or, it's hard to find the introverted nerdy gamer because they don't like going to the clubs, or the person who's a recovering alcoholic who doesn't go to the clubs because they don't want to be in that environment. So I think what we need to do is definitely spread the information to different facets of people, even if that is doing like I don't know. When's the last time I went to a library? When do we put PrEP flyers in the library? Do we put flyers? I know, like, even in Cleveland, like we have signs outside of buses and things like that. That might not be something that's in every city. I don't know if that's a Cincy thing, you know? So I think that broadening our outreach to different sections and communities of people, because you never know where queer people are. We're not always in one spot.
Yeah.
I think that also what we need to do is make sure that we're also outreaching our heterosexual populations, because we know that Black and Latino women, their HIV rates are increasing. So we need to outreach to those people as well. The biggest thing as professionals, I think, making sure that our network is strong. We are not always going to be everywhere. Akima is not going to be in every place, just like Adam is not going to be at every place, like Heather's not going to be at every place, so on and so forth. So are we doing the work not just when we clock in and out? Are we like, are you going to, let's say, for example, if I am in a book club, am I making sure that before y'all go, I know it's nothing to do with book club, but I'm going to give everybody 3 flyers. Can you just put one at your workplace, one at another hobby, one at your gym? Boom. It's hard to do that sometimes, because that means we have to have uncomfortable conversations with people who are not in our environment, don't have the knowledge we have. But that's what we have to do to stop this. So we need to make sure that not only are we outreaching to people we don't know in the professional sense, when you clock in and you talk to your community outreach chair, but even just taking like 3 flyers or putting a link on your social media, send it to your auntie on Facebook, who you know she's gonna be like, PrEP use, grandma, auntie. Just say, you don't have to open the link, just send it.
Yeah, no,
Reach
right.
reach out to the people who are in spaces that you're not at.
Yeah, we do have to get a bit less pigeonholed, and even just the way that we present it. I think that that was a thing too when PrEP commercials were in their infancy. It was so much. Look at this like
Everybody's
tall,
at the club.
right?
Like,
It's a shirtless
yeah.
white dude with a six pack, and I'm like, I don't really see myself in this. And I'm also like, at the time
Right.
when PrEP like was being really when commercials were out, I was like, I don't have sex that often. Why would I need to take PrEP?
I don't
You know, and
either.
that's before I really got
Right.
into the field. And I was like, I don't see myself in this. I don't know anything about this. No one's really like telling me that I should
I
take
mean,
it.
if we really get nitty gritty with it too, like I don't think that we focus as much as, let's have a commercial with somebody in the go-go boots and the mini skirt standing on the street. Let's do it. Let's have an advertisement with people posted up outside of an abandoned house. You don't have to show them doing anything, but just post it up, being like, yes, PrEP exists in these environments too, and these are
Hmm.
people who need it just as much as the hunky hot couple or the people laughing in bed or the people outside of the club, so on and so forth. You know what I'm saying? So let's focus
Or the
on
average guy at the AA meeting, or the guy with the
yeah,
glasses in the bookstore who is like eating a croissant and knows he shouldn't be. Like really
right.
expanding our scope of like who PrEP for and what it looks like, so that so many people
Yeah.
stop having the idea that PrEP is for gay men and those gay men are sexually successful and that's it. Because that's a lot of what the
Yeah.
messaging is. There has been a lot of changes in that, but I think that those changes feel so almost, I don't want to say lazy, but like we've had so many different kinds of look at the hot gay guy in like a hot gay guy situation, and now it's just like here's a trans woman standing here in a colored background. You know, it's not the same amount of fervor that goes into those advertisements and productions. Um, so I
Yeah.
see what you mean. Um, so just so that we can, because I feel like we could talk for like hours, but just so
We
we could,
can.
right, move to our kind of our final thoughts. What's one thing that you would tell the prevention community about young queer POC and HIV prevention? Like, what is this like? This is the important thing. If you didn't hear anything else, take this.
That's hard. Okay.
Isn't it?
Give me 10. Give me 10 seconds. What I want everybody to walk away with is this. Our moving forward into our next step of ending the HIV and AIDS epidemic is acknowledging that PrEP is not just about gay men, trans women, and queer people. And it's not just about sex. It's about trust, it's about community, it's about care. And when we stop putting the gay and the trans at the forefront, it allows us to build a community of people who are both knowledgeable and aware of HIV/AIDS prevention and treatment so we can support all of each other in ending the HIV/AIDS epidemic.
That's good. I think it's also you bring up an interesting point. It is hard to be like the face of this thing because for a long time nobody cared
I
that.
mean, not for me.
No, I mean like I'm talking about like queer black people as the priority population, particularly queer black men. Um, but I think that is tough, especially when you're not engaged in this kind of stuff and this kind of work. And we only recently became the priority population, but for years we were dying at the highest rates and we were being diagnosed at the highest rates. And then we still are. And now people care. And it's like, oh, okay. And the people around us are like, you are the face. You are the person I think of when I think of this thing. And many of us didn't ask for that. And so that can be really hard.
Right.
When it is so much more about the interconnectedness of the community. It's more expansive than, oh, you're black and gay, you should be on PrEP. Oh, you're black and gay, do you have HIV? And people having those perceptions still, and providers having some of those perceptions. So I think that was a really great final thought. I wanted to turn over. I think that we may have a little bit of time. Did anyone have any questions for Emmanuel?
Well, we've got a couple questions in here. I think a lot of them you've already touched on, but there's a couple of them that you haven't that are pretty specific. So I think this one is more for Akeem, but I think both of you probably have something to say about this. So go ahead. But we have an anonymous attendee who said, "Hi, Akeem.
Hey.
When you are encountering complex PrEP access navigation, do you try to include your patient or your participant, I'm sorry, in those calls if possible, or asking how involved are the people that you're navigating?"
Oh, that is so case by case. There was one person I was navigating who was on the phone with me with their insurance company for the whole 3 hours that we had to do it. And I brought in one of our pharmacy team people who was a lot more threatening. She's really fierce at getting people covered. And so they were there. There are some people who it took 3 different days to get all of the stuff I needed together for them to get covered. And they had an unusual kind of insurance as well. So, but the good part is that we got them covered, but it really depends on the patient, their availability, and their willingness or desire to be involved in it. What I do is not secret. So I don't ever intentionally try to exclude the patient or say like, no, you don't need to, or I don't want you here. Anything like that is like that. But I do try to make it as convenient for them as possible. So they don't have to know the amount of work that went into getting them covered. I just want them to be able to come to me, get what they need, and go on with their life. But there have been people who have been right there, and we were both like, at the end of it, like, damn, but we got it done.
Thank you. We've got another one in here that says, what strategies do you use to engage PrEP clients to stay connected to their provider and or coordinator to ensure individuals stay on PrEP? Basically getting at, how do we keep people from falling out of PrEP care?
Oh, I think one of the things is have good providers. Have good, interesting providers who actually care. I'm lucky in that I know many of the providers in our network who are not just like I know them, but I know that they're good and I know that they care about what they're doing. Again, a good or a bad provider can really make or break the experience, especially if we're talking about something like telehealth where you're being touched by less things. Like You don't have to worry about parking at the hospital, which even if you work at the hospital, you know that is Manny, I can cut. That is ass. Parking at hospitals sucks. Um, but you don't have to worry about that. You don't have to worry about having to find your way around to the clinic if it's your first time or if the clinic moved. You don't have to worry about is this person, this MTA or this front desk staff person going to make me feel weird about the way that I have shown up today. All those things. The provider really, when it comes down to it, they have to be good. And knowing good providers. Also, sometimes we have to be bugaboos. There have been people that I've done navigation for that did not really seem to care for me that much, but I continue to show up. And I've changed a few minds. Some of them I haven't, but um, continuing to do reminders, continuing to contact people, and not like marketers, constant contact. We don't do that emailing stuff, but continuing to be to do what our job is and to make sure that people have access. Make sure that, hey, were you able to pick this up? Do you need anything? Do you need transportation? Is there something else going on? Making sure that you know about the resources in your community in case this person drops a thing about like not having access to food, so you know where you can send them or how you can help them. Um, I think too long didn't read is engage with the person as a person and don't send them to shitty providers.
Great advice. Great way to boil that down. Let's see. I got another one here from, this is an interesting question that we run into a lot at Caracal. What advice do you have for clients who are on their parents' insurance and do not want the prescription to show up on their parents' insurance? Are they any, are there any loopholes around this that you know of?
I I don't know of any good loopholes. Manny, I saw that you
Is this
unmuted.
Yeah, I was gonna say, I think it also might depend on the age of the parent because I know that like the parent wouldn't be able to get your medical information over 18, but like I mean they could still like see like you got a prescription, but do they know what the prescription is? You know what I'm saying? So I think that could be a little
Hmm.
cool for somebody who's over 18. But like Akeem, you could tell me if I'm wrong.
No, I don't think that that's. I, so essentially, no, you're not. But ELBs and oftentimes people don't even know what happened like when they went to the hospital. They don't know all the stuff that got paid for them until
Mm-hmm.
they get an explanation of benefits. You can withhold
Mm-hmm.
ELBs if you go to PEDS providers. They can mark appointments as confidential so that that information won't be shared. So sometimes it takes a little bit of extra legwork. There's no like easy solution. It's making sure the insurance company does not share the EOB with the main policy holder. It's making sure that if they are being seen by a provider that can mark the appointment as confidential, that they mark the appointment as confidential. So they won't be able to look into their chart. Generally speaking, um, I've seen that it happens a little bit less often. For example, my little brother is on my mother's insurance, and he's pretty independent. He goes to his own doctor's appointments, and she doesn't get his stuff. Um, and he doesn't go for anything sexual health related that I know of, but like he goes for other reasons. But she doesn't get his information, and so it's gonna take contacting insurance companies. I haven't found a way that's like completely vacuum sealed 100%. This is gonna work, except for confidential appointments, and insurance companies not sending EOBs for those.
Thank you. We only got like 4 minutes till this cuts off, but one of the last questions that I wanted to make sure we got to was, you both kind of touched on this a little bit, but I just wanted to see if you had anything else that you wanted to add to it. One of the questions that we got a little while ago is, how do you think we can get more access to PrEP to Black and Brown communities? Just a general question on that.
I think the first one, and I'll just jump in. let's make sure that we have members of our communities in our teams. I think that it's very hard to navigate how do you get access to PrEP to communities that you are not a part of. And unfortunately, there is still like I said, a stigma about Western medication, but also just about a person who is white or white passing coming into your face and saying you should take this medication. There is still a fear and still a I don't know you, I don't trust you that is associated
Yeah,
with that.
apprehension.
And I think right, that apprehension. And I think that acknowledging that is okay because we can't change it until we acknowledge it. So let's make sure that we have people who come from the same communities, and also be in those same spaces. So like in Cleveland, we have people who are in the ballroom scene. If you're not familiar with ballroom, think Pose, think Vogue. And those people make sure that there's navigators at the ball. Cleveland, we also have a large poetry and jazz scene. We sing all jazz. Hey, cool. But let's make sure that we have people who have access to those scenes as well, you know? So make sure that there's people at each spot in them.
Yeah, and I also think that kind of to synthesize what Emmanuel has mentioned earlier, it's so much about community and connection because there have been people who come up to we'll talk to a community group or we'll go somewhere and there will be an aunt who says, oh my god, my nephew needs this, or oh, I didn't even know this was a thing, can I send my nephew to you? Where interconnectedly we listen to each other. We get a lot of information from each other. So if we can reach grandmothers and aunts and entire communities, not just, hey, random 21-year-old, you know, coaches, we have to be a lot more expansive with who we're talking about because we have to reach everyone because we are communal.
It's great. Thank you both. That is all the time we've got today, everybody. I'd like to thank Akeem and Emmanuel for a great presentation. Thank you so much.